Welcome to our webinar on finding potential CalFresh participants using your MediCal caseload data, a step-by-step guide. Before we begin, I wanted to cover a couple of things. First, you should have a toolbox or dashboard on your webinar screen that allows you to ask questions throughout the presentation, and we'll cover those questions at the end of the webinar. Second, we'll be sharing the slides and the recording from this webinar via email and on our Alliance website, so it will be available for you to review or to share with your colleagues after we end the webinar today. And Sarah, I'm advancing the slides, but I don't know if it's doing it. Sorry about this. A quick technical. Okay, let's see. Maybe you can advance for me if you'd like. Thank you. I also wanted to say a few quick things about the Alliance to Transform CalFresh. We are a group of 7 statewide advocacy organizations that work to improve access to CalFresh through administrative advocacy, research and analysis, and supporting counties and county-level advocates to implement promising practices. Our goal is to raise the CalFresh participation rate overall and with no county below 70% over the next few years. We focus on 4 data-driven strategies that include same-day service, reducing churn, dual enrollment, and equitable access for all. So for today's webinar, we're focusing on the strategy of connected or dual enrollment, and specifically the opportunities available through the MediCal expansion to ensure eligible people can also access CalFresh, reduce their hunger, and improve their health. And next slide. So we can see who's joined us. We wanted to do a quick poll to see who is participating with us today. So I'm going to launch the poll and give everybody a minute or so to respond and share if you're joining us from one of the following agencies: a county administrator or analyst office, joining as a CalFresh advocate or application assister, from the California Department of Social Services or FNS, or from another entity. So we'll give you guys about 5 more seconds. Okay. So it looks like we have a good mix of participants from our advocate and assister agencies, from our county and administration and analyst office, and from the state. We're really glad that you're all here today, and we hope the information will be useful as you think about your strategies to improve access to CalFresh and ensure that people can access both their health benefits and food benefits that also contribute to their health. Okay, so next slide. First, for today's webinar, Diana Jensen from the SF Marin Food Bank and the Alliance to Transform CalFresh, and Anilem Adunye from the California Department of Social Services are going to talk a little bit about dual enrollment, why it's important, and needs to be prioritized. They will also share some important information on the current estimated dual enrollment rates, and lastly, give some much awaited analysis on the demographics of the populations that are currently receiving MediCal but not on CalFresh. After that, Justin Scarfoni from Humboldt County will share the data query that he created in C4 to identify the MediCal participants who are likely eligible for CalFresh. And we'll also talk a little bit about some of the ideas for InReach based on the information that we've been developing. And at the end, we'll answer your questions that you can share again through the webinar question box in your webinar platform. So to start, here is Diana Jensen from SF Marin Food Bank.
Hi, everybody. Let's see, Sarah, maybe I'll have you advance my slides too, just to keep it simple.
Okay.
So next slide. So I just wanted to start by focusing on the question of dual enrollment, why we care about it, how big is the in-reach opportunity, and just for context, I don't think it's a surprise to anyone that the MediCal expansion through the ACA was very successful in California, and so we had this huge increase in MediCal participants. And I think there was some expectation that the CalFresh population, that the CalFresh enrollments would would expand at the same time. And while that happened a little bit, what didn't happen to the degree that folks expected. However, it is still the case that as folks are enrolling in MediCal, when they enroll at the county, the data about those individuals is in the county SAWS system, so C4, CalWIN, LRS, and so it still creates this huge opportunity to reach into our own county welfare office data to say, gee, these folks are likely to be eligible. So next slide. Next slide. So what we did, I partnered with some folks at the California Department of Social Services, and some of you may have seen this already, so I'll move quickly through it. But what we basically did was to say, to consider how to use the aid codes in MediCal to identify people who are on MediCal and likely to be eligible for CalFresh. So you can see here, when you look at all MediCal participants, it's about 30%, just under 30% as of January 2017, who are currently also enrolled in CalFresh. But of course, if we think of the MediCal population as if we think of the MediCal population as being, much bigger than the folks who are likely to be eligible for CalFresh. So, for example, we have aid codes that identify individuals as receiving MediCal through SSI. There are aid codes where we would know that folks would be undocumented or inmates or in long-term care facilities, or they might be aid codes that are specifically designed around MediCal programs where their incomes would be over 200% of the federal poverty level. And so the first thing we do is to peel back the onion of MediCal by saying, let's remove from our in-reach pool anybody who's categorically ineligible for CalFresh. So that would be that outer red circle. Then there's a bunch of aid codes where it doesn't necessarily define someone as likely eligible or not. So an example of that might be that if you are in a MediCal program because you have a certain diagnosis that entitles you to certain MediCal programs or MediCal services, that you might have an aid code that indicates that, but doesn't really tell us anything about your income. Or foster care folks may get MediCal and then it doesn't necessarily tell us what the household income might be for those folks. So then we're left with this green onion. And the work that we did with CDSS was really trying to figure out which of these, how far does it make sense to peel back the onion? So the darkest green is enrolled in CalFresh, and then we have most likely, less likely, least likely, and the less likely has to do with what income level you might be. So we experimented with what's the right tier to consider, and where we ended up was that the most helpful, while still being inclusive enough, was identifying aid codes that would indicate that an individual had an income below 138% FPL. We considered whether we might want to crank that down even a little lower, because there's an even smaller group of folks who might have incomes below the poverty level, let's say. But because the MediCal expansion, there's a really huge group of new folks in MediCal whose incomes are below 138% FPL, who are receiving MediCal through that expansion. And for many of them, they may actually have income that's lower than that. And so we wanted to make sure we excluded enough folks, but we didn't want to exclude that whole pool. So that's where we ended up. When you hear now, moving forward, the most likely eligible or likely eligible for CalFresh, we're talking about MediCal participants who are not categorically ineligible and who have incomes below, according to their aid codes, below 138% FPL. And where we can see the statistic here is that statewide, close to 40% of those folks are currently enrolled in CalFresh. But when we look by county, this is a lineup by county, and I know the county names are small, but that's sort of by design. It doesn't really matter for the purposes of this slide that you know who's who. We can see that the county that has the highest dual enrollment rate up here has a 60% of all likely CalFresh eligible MediCal individuals in this county are actually enrolled in CalFresh, as opposed to the least dual enrollment rates, which is 23%. The state rate is in the middle there, is that gray bar, it's 40%. And it really sort of gives us a sense of how variable this is by county. And in some counties that really may suggest that there's room to reach more folks. I would also add here is that this also shows us that this exercise of identifying the most likely CalFresh eligible folks, it's not, it's really an attempt to make the haystack smaller. We're not going to end up, as Ineligible said, we're not going to end up with, a pile of needles. So we're trying to end up looking for folks who are likely, and that might be 60% are actually going to be eligible. Not that every single person is going to be eligible. I should say I think the PowerPoint will be available on the Transform CalFresh website, and these images are from a data viz that I developed that's available like dynamically online. So if folks want to play with that later, there's a link within the PowerPoint that you could follow. Here, this just shows us that the relationship between dual enrollment rates and CalFresh participation is really strong. On the y-axis is the PRI, and on the x-axis is the percentage of likely eligible CalFresh participants also enrolled in CalFresh. So we can see that counties that have higher dual enrollment rates also have higher PRI. So then this raised this question, which I was really curious, and folks at CDSS were really helpful in being able to provide some information on this. As counties think about targeting in-reach activities for likely CalFresh eligible MediCal folks who aren't already enrolled, it's sort of helpful to understand a little more about who those people are. So if the unenrolled likely eligible population, fits certain demographic characteristics, you might target your efforts in different ways. I should say that we don't necessarily expect that those who are unenrolled look necessarily different than those who are enrolled. That's kind of not the point of this. The point of it is to say, well, who are we trying to reach? Who are we trying to do in-reach to? And what does that tell us about how we might want to tailor our work? So I'm going to share a few slides here. This shows for each one of these charts, the bar that's all the way on the left is the statewide breakdown, and then all of the other bars are the largest 19 counties. And that was what CDSS was able to share with me. For smaller counties who might want to know the same breakdown, I'd be surprised if CDSS wouldn't share it directly with the county. They did this analysis out of meds. I think they're trying to be cautious about breaking down small populations and sharing that stuff publicly, but I would think that CDSS would be able to share these breakdowns directly with county administrators. So here's what we see ages. So the blue groups are children, the green groups are adults, non-senior adults, and then the purple groups at the top are seniors. And generally what we see is that, non-senior adults are the biggest group in all counties that we have here. And actually the youngest cohort of that group is often the largest, so ages 19 to 29. And then that sort of raises some interesting questions that, as always, these things raise as many questions as they answer. So, based on in a particular county, you might know better in your own county, like what share of those are likely to be students. Maybe there's a really large student population. And, for those that aren't students who are in that younger population, is it likely that you might have some lower income young adults who maybe don't think that CalFresh is like quote unquote for them? And if if that's the case, then that there might be a targeted in-reach campaign to that certain demographic. Children typically make up anywhere from 20 to 25% of this likely eligible population. But the thing that really popped out at me was that they're almost all school age. So we don't see a lot of sort of the 0 to 5-year-old, like preschool or infant age. It's really all school age. The one exception to that, notably, is San Francisco, which has a much smaller share. It's still school age, but smaller share that are children. And San Francisco is sort of famous for having a very small population of children. So then we also have seniors, and seniors typically make up 10 to 15% of this target population. And what I really notice here, again, is this sort of this subgroup. You have more like the baby boomer crowd, so that's ages 60. I'm sort of shorthand calling this the baby boomers. It's sort of the youngest group of seniors, age 60 to 69. It's always the biggest group. And so again, it's being thoughtful about, if we're going to reach out to seniors, how do we target messages to them or refine them based on what's going to resonate? You know, maybe there's some messaging that's around the elderly simplified application program that's rolling out, or you know, it may make sense to coordinate with senior service providers to make sure that folks aren't, you know, seniors are often concerned about sharing personal information if they're concerned about fraud or elder abuse. So, you know, connecting with trusted community members. There's sort of 2 more charts here, and I want to make sure to give Justin enough time, so I'll kind of move quickly here. This one is about race and ethnicity of the likely eligible but not enrolled population, and there's a lot of categories here, so I struggled with how to color them, and I hope it landed okay. The biggest take-home points here is that the 2 largest groups in the target population in nearly every single county are Hispanic and white. Again, San Francisco is an outlier with a large Chinese population. And then there's a few, but the racial and ethnic breakdowns really vary a lot by county. So one thing I noticed is that a handful of counties report a pretty large share of their target population as just Asian Pacific Islander, which seems like that may be being used as sort of a catch-all category. And so there might be more digging that would be useful to understand, you know, what population we're really looking at there. And then in some counties, the target population is largely composed of really only 2 or 3 major groups, whereas in others, there's a really like much broader, more diverse spectrum. The other thing I want to point out is up here, these sort of light bars, these gray bars, is other missing, declined, or there's no doubt valid data. On the one hand, it's a pretty big chunk of folks with no information, but most counties do have data reported for at least 85% of this target population. And I want to add, this isn't up to me to do. CDSS would have to help out, but it would be interesting to cross this data with the age data. In other words, like, are the children, you know, the children, do their race and ethnicity breakdowns look like the entire population of the target population, or are we looking at, you know, largely Chinese families with children? That would, again, help to sort of figure out how to move forward to do targeted in-reach. Finally, we've got language, which it's interesting, with the exception of Imperial County, which is the very last bar there, the largest reported language is almost always English, and that's usually followed by Spanish. I don't know for sure, this is sort of a question mark, whether the language field that's in MEDS usually indicates the primary spoken or the primary written language. And I also know that it can be the case that non-English speaking clients with limited literacy will sometimes opt to receive materials in English with the expectation of seeking help from someone else for interpretation. So that's, folks might know their own counties a little better around that question. Let's see, you know, this again just helps us understand how our in-reach efforts might be the most effective when they're kind of tailored to be culturally relevant to subpopulations. So again, you know, I know San Francisco is the place that I know best. You know, there are certain community partners that have really strong, trusting relationships with their with low-income communities of certain populations. I suspect that's true in many counties. So leveraging those relationships can be really valuable when you're doing this kind of work. Finally, I'm just going to say, just to sort of sum up, that their demographics, they really can help us guide, like at the county level, what our county level strategies might be, what kind of tailored messaging around, certain key populations, and then our strategic community partnerships. I do want to give a chance for Inalam to pipe in about, from a CDSS perspective, about, what thoughts he has about the demographic stuff and kind of what opportunities might be there for county folks to get some support from CDSS in understanding this in-reach population better as folks move forward.
Okay, my name is Inalam Adunya. Again, this is great work by Diana, always asking important questions, which is helping us a lot. And these are a lot of questions here, which will take up to continue what we do. How will these numbers be meaningful for counties, especially at local levels, at neighborhood levels? The demographic information that was supplied here at the county level, the age breakdown, ethnicity, language, what does it look like at neighborhood levels, where actual targeting takes place by counties, by outreach groups, by CBOs. To this end, we have been doing work that has taken us to 17 counties so far. We called it a geocoding, CalFresh geocoding pilot. Some of you in the audience may be aware of it, may have been in the group when we presented. Where we focused so far out of the work that Diana did so far is language. We have not put a lot of emphasis on dual participation, and we will do so going forward. Not a lot of emphasis on age breakdown. We'll do so going forward. But when it comes to language, county after county, we have shown that language is very important. In particular, being isolated linguistically in a sea of populations that spoke a different language, in particular English, that is detrimental to outreach. So there are pockets of areas where a sizable number of eligible folks live, but very small percentages are receiving benefits. So far our work zeroed in on language, how important that was for outreach and as a factor to consider in increasing participation. Our work is being informed now by the added urgency after we now have the privilege of working with Kim McCoy-Wade, our new CalFresh chief. She's giving us direction on how to move forward in helping counties by identifying areas at community level, at neighborhood level. And to this end, we actually came up, the CDSS, the Social Services Branch, came up with a highly advanced, revamped version of the CalFresh dashboard. We now call it Dashboard 2.0. Hopefully you'll have a chance to visit. It's out, it's active, it's ready. And to that, we have linked special interactive web maps at county level. Some of the information presented in here, especially in particular language, is attached to this Dashboard 2.0 as a county level interactive web map. You can click on your specific county and get information on linguistic characteristics of the population at county level. Another interactive map that we have linked to this dashboard is participation, where we looked at the number of folks receiving benefits and what is that number out of the total number of folks eligible for benefits. And this we did at zip code level. I invite you to check the county dashboard 2.0 and click on that link on zip codes. Again, this is great work by Diana. A lot of questions again. We have our assignments. And Diana, did you want me to add anything else? Anything more?
No, I just wanted to clarify. It sounds like there's a possibility that you guys might do some mapping work or something actually using the dual enrollment data, like as opposed to population based. Or we can save that question for the end if you want.
Yes, incorporate this aspect, dual enrollment in the neighborhood level analysis that we do.
Okay, great.
Yes.
Perfect. Okay, so I think we're going to hand it off to Justin now. Justin, I think you have control of the slides.
All right. Hello, everybody. Trying to get this to move along here. There we go. All right, so my name is Justin Scarfoni, and I'm a CalFresh Outreach Analyst with Humboldt County. So I'm just going to talk a little bit about our approach here and our project that we started up in the last few months, and some of the information we've been able to have or find from it, and some of the reports we've been able to build. So to start us out, just a little bit of Humboldt County data. So just to give you an idea of the size of our county. So for MediCal, we had about almost 30,000 cases, a little over 50,000 individuals, and about 35% of our MediCal cases do have a CalFresh component. For CalFresh, we're almost 12,000 cases, a little over 20,000 individuals, and about 91% of our CalFresh cases have MediCal. So, as some of as the previous presentations have talked about, why dual enrollment is a priority. We've seen since ACA, we've seen a really big increase in our MediCal. Sorry about that graph there. A really big jump in our MediCal population, but our CalFresh population, that bottom line there, has stayed fairly constant. It's raised a little bit, but not exactly the jump we were hoping to see. So basically, we were left with the question of, well, how can counties identify these likely CalFresh eligible MediCal recipients? And this question was raised actually at the Dual Enrollment Summit held by the Alliance to Transform CalFresh at the end of January of this year. And, they had a lovely summit that talked about dual enrollment, and we broke up into some groups, and I was a part of the data group. And us being, data driven, we said, well, what can we do to identify these people? And the simplest solution was obviously, well, let's make a report. Let's find a report that we can use that'll pull our county information that we can aid us in identifying these likely eligible MediCal customers. So some of the criteria for this report was we thought it was really important to make it in a shareable format so that all C4 counties, at least, Humboldt County is a C4 county, so that's the direction that we went with it. Just being able to have this report, anyone or any C4 county would be able to pull the information from their own county data and use this to identify these recipients. So in that report, we're going to include things like MediCal aid code information. I think that's the main driving force behind identifying these people, income, household size, and some other pieces of information. There. I'm not sure what happened there with the, oh, there we are. Sorry about that. All right. So we're having a little bit of technical difficulties here. Let's see if I can get the slide back together here. There we go. And so now, sorry about that. The last step here is going to be combining this report information with this lovely MediCal aid code methodology spreadsheet that actually Diana, who was an earlier presenter, created. And that was, it's related to how she was talking about with the tiers of likely eligible aid codes. And so she provided a really nice breakdown of that. So we used that information with this report that we built to identify these folks. So we'll look at the report itself now. So it is available for any of you C4 counties. It is available on the C4 web portal. If you go to resources, resources by functional area, ad hocs, ad hoc shared reports 2017, and it is the 013-2017, and it's called Active Persons on MediCal, where no one on the MediCal program is also enrolled in CalFresh. And so essentially, this is just a little snapshot of what the report looks like. So we have information on there such as case name, case number, person name, SIN, aid codes. We made sure to list any or all aid codes that that person may have associated with them. As we know, some individuals have more than one aid code. We did include age information, citizenship information. We did include some income info. As we know, some of the ways that MediCal and CalFresh treat income are different. So we figured if we have some reported income in our system, we wanted to use that information. Then we included things like household size and then some contact information. The idea there being when we did filter this list down, we could hopefully use this as a list to contact people. And then also some demographic information there. So then we took this report and we combined it with this MediCal aid code spreadsheet that Diana Jensen provided to us. And this is just a little snapshot of what this looks like. And she did a great job of breaking down each aid code with a name, listing the scope of benefits, if there was any FPL associated to it. And then also the last two columns are really the real important ones here, being potentially eligible for CalFresh, if there were never eligible, and then also the inclusion tiers, which she talked a little bit about. So basically we have 3 inclusion tiers, tier 1 being that most likely eligible under 138%, tier 2 under 160 with no share of costs or maybe a share of costs, and then that last tier may be eligible. So we basically took the information on both of these and used this to find the target population. So I'm going to go into how we did that. So our data analysis. So essentially, from the initial number we got from our report was we found that we had a little over 30,000 individuals in Humboldt County that were on MediCal, but not associated to a CalFresh case. This was about what we expected. We have about 50,000 on MediCal and about 20,000 on CalFresh. So it makes sense that we're looking at about 30,000 people here. So our first step here was going to be removing those categorically ineligible aid codes that we talked about a little bit earlier. So we took all of our individuals and we said, if any of them have any of these categorically ineligible aid codes, we're going to go ahead and remove them from this list. And for our county, we only removed about 1,600 individuals. So that, I imagine, would vary by county. It wasn't as large of a population as we thought it was here. So then we went on to the next step, which was identifying our likely eligible individuals. And we really focused on that tier 1 under 138%. So after we removed all of our ineligible individuals, we then went and did a count and said, hey, how many do we have that are in a likely eligible aid code? And that brought us down to about 20,000 individuals. Still a pretty high number, but we're chiseling our way down here to a target population. So now the next step was we said, okay, we want all of the members in that household to have a likely eligible aid code. So the reasoning behind that being if there's somebody in the household that's ineligible, that we really wanted to focus on households that all members were likely eligible. We think that we're going to get the best results from that. So to do that, what we did was we compared the number of individuals in each case with the tier 1 likely eligible aid code, and then we used that with the household size information. And if those numbers matched, then we went ahead and said that that was a target population. If those numbers were off, we went ahead and said we're not going to target those at this time. So what that did was that brought us down to about 16,000 individuals, so cut us about in half, or about 13,000 cases. So again, we're still at a fairly high number, but we're chiseling down even further. So now the last step that we did, our step 4, was removing cases with any reported income over 138%. And that's why we use that income information there in our report. And that's because, as we know, the MediCal and CalFresh deal with incomes differently. So if there was, for any reason, reported income in the case, even though they were in an aid code that was maybe under that FPL, if they had reported income over that that 138%, we went ahead and removed those individuals. So that took us to about 13,000 individuals, or about 11,000 cases, which essentially we went ahead and called our target population. So we've been working on this over the last few months, and so we just have some basic ideas now. What are our next steps going to do? So we really just kind of identified these folks, and now the question is, well, how do we target them? What is going to be our in-reach strategy? So basically, I'm in the process now of doing a PDSA, a Plan, Do, Study Act, which essentially we're just taking a small sample, about 100 to 150 cases. We're reviewing the MediCal case information, and then we're contacting those customers to find out, is there anything that we can identify as to places that these applications are coming from, or what are the reasons they're not engaged with CalFresh? Are they just not interested? Did they not know about it? Did they not know they were maybe eligible? Not enough time to do the application, things like that. So we thought doing a sample population to get a better sense of where these customers, where are we missing getting these customers enrolled, would help us with our in-reach strategy. So dependent on these results, we're kind of in the process of that right now. We're going to work on targeting some of our strategies. So some of those things would be, like we talked about earlier, marketing materials and really enlisting our community partners. So in Humboldt County, over the last few years, we've developed really good relationships with a lot of our community partners through the CalFresh outreach program. And so we're really looking at, are there ways that we can really involve our community partners? And if we see that we have a lot of seniors that maybe are on this list, is there something that we can work with our Humboldt Senior Resource Center to filter these folks in? Also in Humboldt County, we're a very rural area and we're pretty spread out. So we have a lot of smaller towns, and transportation can be an issue for many of our folks. So is there a way that we can work with some of our family resource centers or some of our other partners that are in these more rural areas to really help us get these applications and increase these, our dual enrollment numbers? So other ideas were evaluating our intake processes. So again, just trying to figure out, where are we missing these? Are these coming from California, that they're just not getting CalFresh information? Or are we missing them when we're registering these applications? Or, is there anything that we can identify to improve our processes to increase this number on an ongoing basis? And then also develop processes to evaluate these cases at RE. So instead of looking at 11,000 cases all at once, is there a way that we can update our RE processes to really be asking those questions and really making sure that we're engaging all of our MediCal customers with CalFresh information? And then another thing that we've been doing, but we're going to continue to do that, is just making sure that CalFresh information is given to every customer at all call center contacts. So anytime we have contact with that customer, making sure that we're reviewing that case and we're looking and letting them know they may be potentially eligible for CalFresh and trying to get those applications there. So some other ideas that we've had, and actually this was one that we got from the Dual Enrollment Summit, was actually a dual enrollment application competition, and basically having our units here battle it out over who can collect the most dual enrollment applications each month, and have a trophy or a small prize or something that kind of rotates around to the winner. We've had some really good luck with these sort of competitions in the past. They seem to be good for everybody. They build team morale in our county folks, and then we're increasing the number of CalFresh participants. So seems to be a good plan for all of us. And so that's about it for Humboldt County. That's our plan, our next steps here, what we're planning on doing. I did just want to give a couple of special thanks to Diana Jensen, also that presented earlier, for all of her work with the aid codes and really helping me out throughout this whole process. C4 ad hoc reports team for building a report that's shareable for all C4 counties. So hopefully some of the other C4 counties on the call today will be able to utilize that. Stephen Sauer, our local workforce management analyst, for all the data analysis he did. Obviously CDSS and the Alliance to Transform CalFresh for having us all here today. And with that, I think.
Yeah. Thanks, Justin. That was a really incredible breakdown of both your process and then how you're planning on looking at the information. And I love that you guys are doing a competition with that amazing looking award that you pass around between the units. That's great.
Exactly.
Everyone, feel free to send in any questions that you have, either for Justin about how they went about creating their data query, or questions about how they plan on implementing the data that they found. Also, any questions for Diana or NLM about any of the demographics data that they've collected. As you can see from these two presentations, there's two strategies that your county can implement. There's that general high-level strategy of identifying the key populations and kind of being able to do an outreach to those populations directly to make sure that they are receiving both MediCal and CalFresh based on language, ethnicity, targeting your strategies towards age, demographics, and things like that. And then there's that more detailed approach that your county could undertake, where you go in and create that report, pull the data on those specific households, and start thinking about how can we find out why these households aren't involved and what can we do to help bring them along, either doing a targeted campaign to the whole population or implementing strategies throughout the eligibility system to make sure that it's just folded in a regular part of the process. So I love, Justin, that you guys have thought about that, both from the targeting directly to those households to implementing changes within the whole system to make sure that those households get brought in over time.
I have a question for Justin, if we're waiting for other questions. This is Diana. Justin, I know that you, I remember you were developing, working on developing the ad hoc report that other C4 counties can download as well. Did you, I think I remember that you had also developed a crystal report or something that allowed you to process that information easily, to identify the, to call down that big MediCal list into the target population. Is that something that you can also share with other C4 counties?
So the crystal report actually is the ad hoc report that was built there. So what I was talking about actually is the crystal report. Crystal is just the data system that we use to pull information. So I believe most C4 counties are using crystal reports. Some may be using, I believe it's business objects. But if your county is not using crystal reports, so this query was built for crystal, but if your county doesn't use crystal reports, the C4 analyst, the C4 ad hoc business analyst has really been really useful or really great in this whole process, and they're able to make that report, the same query, available through business objects also. So
okay, so if an analyst or someone from another C4 county wanted to sort of do what you have done, they could pull down that report from C4 and they would pretty quickly end up with their actual target population, like with a list of that narrowed down target population.
Yeah, so if they go to the C4 web portal that's actually in here, they can pull that, and then that report is built to pull their own county information. So they'd be able to run it through their system, and it would pull all the information from their county. They would have to then go through the process of each of those steps, kind of filtering those that target population out. But yeah, that will pull all the information from their county.
So if folks need any, if they get stuck along the way, are you willing to be a resource? Or
Absolutely, yeah. If there is any questions as far as the data processing goes, I did actually have to reach out for some help there too. Some fairly complex Excel, but it's fairly easy once you kind of get the process going. But I'd be more than happy.
Yeah, my hope would be that since you've done it once, that helps. It's a lot easier to do it the second time than to do it the first time.
And we've actually, the way we built all of our Excel reports were so we can do it on an ongoing basis. It's not just going to be a one-time snapshot. It's something that we can continually run to identify are these new populations or how they've changed.
That's great. We do have one question, and I'm not sure if any of you can answer this, but the question is there a similar report functionality for CalWin?
I think I can answer that. I think not really. I know, however, that one of the analysts in San Francisco who presented at or maybe she was there at the summit that didn't present, has developed like a similar method to pull data out of CalWin and analyze it, but it's not. But like CalWin didn't create a ad hoc report that any county could just go use. So it might be more steps to get from point A to point B, but I think it's doable.
So a CalWin county could basically kind of start a little bit from scratch and go through and kind of draw those elements that we talked about and then create the report similar to the step-by-step process that Justin described, but it would have to be kind of started from their own beginning.
Well, yeah, although I do think, I'm trying to remember, I think after the summit, after the dual enrollment summit, I think we did share around a summary of so the analyst in San Francisco, her name is Perry, and I think she shared her notes about I think she said that the trickiest part was figuring out kind of which fields to use out of CalWin for the aid codes and that kind of thing. And so she did share some notes about the steps that she took that would make it much easier than starting from scratch. So I would say if there's a county that's asking that question, there's someone who's asking that question from CalWin County, certainly they could contact me and I can put them in touch with the right person to get them, as far along the way as possible.
That's great. I think that would be great to not have to completely start from the beginning, but have a guide of sorts to kind of see if that's something that's implementable in their county.
Yeah, and I would say also, in San Francisco, what they did was almost like a mashup of the way that Justin and I talked about this, where they started by narrowing down to that target population, and then they did a bunch of analysis to look at, some of the demographics of that group to see, which were sort of the most, which subgroups in that target population kind of popped out, and that might be the most promising to do sort of a campaign to.
That's great. Another question about the slideshow being available. We will have the webinar available after, probably in the next day or so. It'll be sent out over email to everyone who registered, and it will also be available on the Alliance to Transform CalFresh website, which is transformcalfresh.org. I'll also add, in a few months, we're going to reach out again to everyone who's registered for the webinar to schedule a conversation about how people may have used this data and information. If people were able to create their own reports to start identifying individual people within their system that might be eligible for CalFresh, or if they use the demographic data to start an outreach campaign or an in-reach campaign within their community. To share some of those promising practices or ask some questions about how to kind of overcome maybe some of the barriers that might come up in that process. So please keep your eyes open in a few months for that email to have another conversation and maybe share some learning with each other about how you're doing. And if you do implement some of this and have some outcomes or processes that you want to share, please let us know, and we'd love to have you share and present about what you might have been learning along the way. I don't see any more questions coming in. Anything else?
This is Alan. Just one thing on my mind. In the future geocoding pilot visits, we can create maps at zip code level showing these same percentages that Diana showed. Instead of county level, it would be zip code level. Diana, can I have you confirm that maybe 55% is the highest, kind of the best scenario? And then how close are you to that percentage? Preferably by zip code level. Would that be a good thing to do?
Yeah, I think it probably depends a little on the county about how valuable the zip code analysis is. So I think in many counties, the sort of geography of the population does matter a lot because the way that the offices are organized. Let's say you might be naturally focused on certain geographies, whereas in smaller geographic counties, the overall demographics of the county might matter more. So, for example, again, this is sort of a way in which San Francisco is sometimes a funny special snowflake, but where San Francisco is so small that when we look by geography, it can help us. It can be the most helpful when there's like an existing community partner there that really matches up nicely with the target demographic there. So, for example, if you have a neighborhood where it seems like there's big in-reach potential, there's maybe a certain demographic like seniors, and you have a really stellar senior service provider, potential partner, you could, like, understanding that all those stars are aligning in that place might help dictate what would be an effective strategy. But there are also, I think, effective strategies that are actually countywide, where, for example, in Alameda, where they're sending out, they're narrowing down to a target population, then they're sending out pre-filled, basic information in a CalFresh application along with a MediCal re-enrollment form. And that's not a geographic thing. It's based on a broad target population that they've identified. But I love the idea of having that geocoding work that you guys are doing start to incorporate, both the dual enrollment stuff and as well as some of the demographic stuff that are really specific to these individual people, because it's just that much more specific. And as far as what would be a good target, I think the max that we're seeing so far is 60% for this target population, and that's in the count. That does happen to align with counties that have the absolute highest PRIs. So I think it's probably reasonable to say that 50 to 55% would be a great target for many counties. It's going to depend a little bit on what your MediCal, what kinds of MediCal programs dominate in your county. But I think that's right.
Okay.
Great. Thank you, everyone. I don't see any more questions coming in. So just to let you all know, again, we'll be posting the slides on the webinar. We'll be sharing out the link to the Dashboard 2.0 that includes some of those maps that NLM talked about, and also Diana's link to her data visualizations that she shared, so you can kind of play around with those and see more specifically for your region. And then we'll be in touch in the next few months to hear about any of you that have been able to implement some of these strategies or have started developing some in-reach ideas that you'd like to either get feedback on or share some success from. So thank you again to all of our presenters. The information you shared is really incredible and exciting, and thanks to Sarah for getting the webinar set up today.